Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and chapter immunization representative at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. This is the week of August 2nd, and globally we're up to 199 million cases totally, with over 4.2 million deaths worldwide. In the United States, we now have eclipsed 35 million cases, with 613,786 deaths. In kids, as of July 29th, so through the end of July, the AAP data reveals 4.2 million cases of pediatric COVID, which is 14.3% of the total in this country, and comes out to a rate of 5,578 cases per 100,000 pediatric population. In Arizona specifically, our cumulative caseload is 153,306 pediatric cases, which is 16.6% of our total, and 8,338 cases per 100,000 pediatric population. Importantly, and I think many of you are aware of this as well, the number of pediatric cases, and in fact the percentage of total cases that are pediatrics, all have increased precipitously in the last several weeks, largely due to the impact of the Delta variant. In fact, the week of July 29th had 71,726 new pediatric cases out of the total in the country, versus 1 month prior to that when there were just 8,500 new cases. So significant increases across the board. What does this mean for us, or what does it mean about likely the Delta variant? It is clear now that the Delta variant has increased infectivity for all ages, but it is preferentially affecting and infecting young adults and children. Why? Well, young adults are unfortunately the remaining category of individuals in the States, at least, that are not vaccinated, whether through personal choice or lack of access or inability to do so. Whereas kids, of course, are those under age 12 are not yet able to be vaccinated, although research is ongoing quickly to hopefully get a vaccine indication for younger ages. As well, the uptake of COVID-19 vaccine in those ages 12 years and up is not as great as I'm sure all of us would wish it to be. So both due to lack of vaccine protection as well as increased infectivity, the Delta variant is causing an increased burden of disease in pediatrics. So we'll start off with our questions today. The first one is, how should we address catching up on missed immunizations? Well, this is the million-dollar question, or probably in terms of disease burden, hospitalizations, and loss of function, the multi-million-dollar question. It is clear, I think, from all of our perspective, that the pandemic has been incredibly detrimental to routine preventative healthcare visits in pediatrics, as with other age populations. And a major part of that has been vaccine delay, because we were unable to get the kids into the offices or at least into vaccine clinics to keep them up to date. Well, what do we do about that? First and foremost is to increase the pace and the visibility of messaging. And this is occurring as we speak. In fact, I just got off the phone interviewing with NPR for a story which is coming out of both the AAP and Georgia, looking at the impact of return to school deliberations and calling very clearly and loudly for a return not just to school, but a return to doctors' offices for those preventative healthcare visits and for the updating of those vaccines. So public messaging, which I believe certainly the national AAP is working on, and certainly the Arizona chapter are working on quite vociferously to increase public perception and awareness of the need. But in addition to that, can be our own local messaging. Why? Why is it important to get kids back? And Arizona is probably a very good example for that, sadly. We are in the middle of a pertussis outbreak. Pertussis, a vaccine-preventable infection, which is pretty big news for especially young infants who are infected, who may not yet be able to complete their primary series, or even are younger than age 2 months and not yet able to be vaccinated. Measles. Arizona is no stranger to measles, sadly. So too the concern for tetanus. So too the concern for varicella, for chickenpox. So too the concern for pneumococcus and meningococcus, all causes of severe invasive bacterial disease. So we can point to active outbreaks right now and certainly clusters of invasive infectious diseases which threaten the lives of our children and which can be vaccine preventable if only we can get those kids in to get them updated and or to do catch-up vaccination. So how do we address catching up? Well, certainly just the logistics of this. There are catch-up vaccine schedules which are published every year through the Advisory Committee of Immunization Practices and the AAP. You can find those either through even a simple Google search or in, if you have copies of Pediatrics, those are published every year. There's no new magic to the catch-up series. Follow it. It is pretty clear. Of course, if you have any questions about that, please feel free to reach out to the chapter or to your local infectious disease providers. All of us are happy to work with you to find a good plan to get these kids updated. But then the other part of that, I think, is preparing the opportunities both in our practices, our clinics, urgent care centers, if needs be, to allow for and to support the increased vaccination rates. Hopefully that will be coming as we get more parents aware of the need to vaccinate and therefore more kids coming into the practice. Just as a completely anecdotal observation, I was at Walgreens the other day picking up a prescription, and there was a long line of people waiting to get their COVID-19 vaccine. Not necessarily pertinent to kids, but just that the increasing public awareness of new cases, new surge, new death, new morbidity, mortality from the Delta variant is driving an uptick in vaccination rates across the country and certainly here in Arizona. My hope is that this increased messaging and very vocal public notice of the need to update routine vaccines in kids will have the same desired effect. Fingers crossed. Next question. What are the special considerations for children with special healthcare needs and COVID-19 vaccines? So keeping in mind that as of right now, today, as I record this, August 3rd, 2021, there is yet still just emergency use authorization for vaccination of ages 12 years and up, not yet younger ages. A brief note about where's the data for younger kids. Both Pfizer and Moderna are actively recruiting that data. However, both have been instructed by the FDA, the AzAAP, and their own scientific advisory boards to increase their recruitment numbers to address the possibility of myocarditis following messenger RNA vaccination, such as has been seen with both Pfizer and Moderna in ages 12 and up. Yes, indeed, those cases are occurring. Yes, indeed, there seems to be, at the very least, a temporal link, if not a causal link, with messenger RNA vaccine and mild post-vaccine cases of myocarditis. And so to assess the risk of that same association in younger children will require larger numbers than initially called for. This means, of course, that the timeline for data acquisition and presentation to the FDA and the ACIP for approval is being pushed back now to best estimates midwinter. So, sadly, we will not have a vaccine indication, or EUA, for children under age 12 by the start of the school year, which is in many cases already started and or starting in just a couple days. But hopefully we'll have it before the year is out. Fingers are definitely crossed. To the specific question, special considerations for those children who are old enough to be considered for COVID-19 vaccination. Are there special considerations for those children who have special healthcare needs? And the very short answer for a slightly longer answer is no. There are no special considerations. That said, those children who have had a significant and certainly anaphylactic reaction to vaccines need to be at least considered strongly by their primary care providers, us, and or possibly an allergist immunologist for safety in proceeding. Even though there is now excellent data in adult patients and young adult patients that those who had a type 1 hypersensitivity reaction, we're talking histamine-based, hives-associated, even those who had an anaphylactoid reaction, All of those individuals recruited into a recent study underwent a second dose of that messenger RNA vaccine, and very few had a reaction, first of all, and those who did, either it resolved spontaneously, so self-limited, or responded to antihistaminergic oral medications, so not even requiring doses of epinephrine. So that would suggest that even those children who are 12 and up who have a history of vaccine allergic reactions are still very likely to be safe and able to receive COVID-19 vaccination. Other special categories, children who are immunocompromised for whatever reason, whether they're immunosuppressed on chronic steroids or chemotherapeutic drugs or biologics, they all can receive COVID-19 vaccine with messenger RNA vaccines. The only concern there is they may have a subtherapeutic or less than seroprotective response with even the two-dose series. Adults who fit that category are strongly being considered right now, as I speak, by the CDC for a third dose or a so-called booster dose. And as of yet, there's not a strong recommendation for that, but I would not be surprised if in the next week or so we see that come through the wires. Children, however, can be vaccinated, those who are immunocompromised, and certainly should be as soon as possible. Children with autoimmune diseases are okay to be vaccinated. Children with a history of Guillain-Barré, for whatever reason, whether it's theoretically vaccine associated, although the only true association has been from the influenza vaccine back in the 70s, but a concern for Guillain-Barré from vaccine. Certainly those children who have Guillain-Barré from some other trigger, whether it's viral, infectious, etc., can and should be vaccinated. The rationale here is that the rates of Guillain-Barré and other neurologic manifestations are far higher with actual COVID-19 than they are with vaccine. And in fact, initial early reports of Guillain-Barré following patients, older patients, vaccinated with messenger RNA vaccines were definitely documented, but when evaluated closely, those numbers were found to be far lower than typical expected background or baseline Guillain-Barré cases from other indications. So there is no suspected or predicted causal or temporal link between COVID vaccine and Guillain-Barré. Patients in a very similar nature, patients with a history of Bell's palsy, again, regardless of the trigger, are also okay for vaccine with COVID-19. No special considerations there whatsoever. And the same argument applies. Bell's palsy is a known complication of COVID-19. There's no known causal or temporal link between COVID-19 vaccines and Bell's palsy so far in the very close scrutinized history of vaccine delivery in the world. The final category that I think deserves special mention are those individuals who have a history of myocarditis, pancarditis, pericarditis, anything involving the heart with itis following it. And those are children who, if their myocarditis or cardiac inflammatory disease is unrelated to COVID-19, meaning not from actual disease, not from a MISC or something else related to SARS coronavirus 2, if they are not actively inflamed, not actively on treatment, immunosuppressives, cardiac medications for their myocarditis, then it is okay for them to get COVID-19 vaccine. However, those children and young adults or adolescents who do have some possible link between SARS coronavirus 2 or COVID-19 vaccine dose number 1 or COVID-19 MISC or etc., those are individuals that should hold off on COVID-19 vaccines at this time. It's very similar to those who have suffered from multisystem inflammatory syndrome in children, MISC, who also are currently advised to hold off on COVID-19 vaccines because of the potential of a overly robust vaccine reaction by their immune system, which might target the heart yet further. So those are really the only special considerations. Otherwise, it is sounds horrible, but a carte blanche to proceed with COVID-19 vaccines in all ages, 12 years of age and up and going further. As an additional note, although this won't be as frequent in our pediatric population, but those pediatric patients who are pregnant or who may be pregnant, again, the data is coming in very strongly in support of vaccinating women who are pregnant or think they may be pregnant with COVID-19 vaccines, especially the messenger RNA vaccines. The safety studies are excellent, and the seroprotective responses are also excellent. Further, those women who are pregnant and have been vaccinated already, their babies, both in utero and then also post-delivery, their babies have been doing quite well with no reported signals, meaning no reported abnormal findings or concerns or presence of active viral RNA or anything like that. So those pediatric patients who are or who might be pregnant are also included in the proceed with COVID-19 vaccines. All right, third question. Do I have any insights or guidance to share about how to lend support to our patients and families and even our own clinic staff or center staff as the school year begins? So I think, again, we are probably all painfully aware of the issues, but just to put them out on the table, I think we are all aware that Governor Ducey has passed legislation or has decreed, and it's been supported, legislation which makes it illegal for school districts to create mask mandates or vaccine mandates. Now, importantly, this does not mean that school districts and schools are unable to support the use of masks and support the use of vaccines. This is not anti-mask or vaccine necessarily. It's against having the requirements for that for school entry, although I think many of us would suggest that those two are the same thing. But instead, what we have is an incredibly confusing array of school districts trying to navigate how to proceed in this delicate and I should suppose legally dangerous territory for what to do about mask strategy and vaccine strategy as the schools open their doors for kids, and some already have. FYI, there is a school district in Pima County, where I'm recording this from, that has had an explosion. I use that word not lightly, an explosion of pediatric cases who were confirmed. Thankfully, mostly are mildly ill, but there have been hospitalizations, some of whom have required ICU support. So this is not an innocent, simple issue. This is school children being put at risk by a variant and by a virus which now seems to be targeting school children preferentially. So, with that being said, how do we help our families decide what to do? Send their kids back to school? Yes, I think we all can support the need for in-person education for the social reasons, for the emotional reasons, certainly for the mental health reasons, and also just because education is far better when it can be face-to-face. But I think we would all equally support, and I hopefully can verbally do so, doing so safely. So strongly supporting voluntary use of masks, and even those school districts that are increasingly going out on a limb and creating mask mandates. And there are several school districts around the state that have done so. Yay for them, clicks, support, etc., and so forth. I think ultimately that is what would be safest. How do we help our parents make that decision? And I think both couching the conversation in terms of personal safety, pointing out that it's not just COVID-19, but other respiratory viruses, other viruses which are out there, which are currently and actively hospitalizing our children. And every time a child gets one of those through attending school, not washing hands, not wearing a mask, etc., and so forth, that's a child who's going to lose school time. And that means likely the parents are going to lose work time because, loss of school, loss of work, loss of function go hand in hand if the parents have to be home taking time off from work to care for their child. So putting into both a financial burden as well as the fact that children who get sick by not wearing a mask and potentially are hospitalized are going to be at risk for a whole bunch of other things, right? Hospital-associated infections, while rare, are yet still a risk. And that's going to further increase their time away from school, which will delay their education, delay their involvement, delay a whole bunch of things. So there's personal health issues that I would imagine and hope that many parents would respond to in some way. But there also, of course, is the societal responsibilities that whether or not the parents are worried about their own children, there are other classmates who may be immunocompromised, who may have cancer, who may be actively on chemotherapy or immunosuppressives. And so could they not do the right thing for their society, for their mini family in the classroom, to protect everyone? And the easiest, cost-effective, evidence-proven way to do that is to wear the darn mask. So I think, obviously, it's hard to predict every situation, every conversation, but those are two avenues of approach, just as I think many of us have taken with vaccine hesitancy in other areas. So all those apply right now. The added concern, of course, is that Delta variant is now far more infectious among kids, and it is game time. It's game time. The only way to get through the Delta variant and hospitalizing kids and young adults is to both vaccinate those whom we can and to wear the masks. So those are the questions. Obviously, this is a very dynamic, labile time. I imagine all of us are navigating very difficult conversations, very difficult situations with varying degrees of both vaccine uptake as well as mask uptake, and even just vaccines for other things, especially including routine preventative vaccines against pertussis, varicella, et cetera, and so forth. So all I can, as a sort of a summary statement, offer is to try and take the deep breaths, to try and couch these conversations in terms of personal and societal benefit, to realize that many people are just afraid and tired, very human, very understandable emotions, and yet into that blackness and void, we can offer a glimmer of hope, a glimmer of light through vaccines, through support, through hearing, confirming our parents' concerns, and then offering perhaps hope and an alternate dialogue with which to follow. So with that, thank you for listening to ID Talk. AzAAP members can submit questions for future episodes to covid@azaap.org. The Arizona AAP chapter would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. Meanwhile, keep breathing, everyone. Hang in there. And thanks for listening.